Hello, I'm Dr. Nebal Wail. I would like to discuss a session for the sixth grade medical students. We will discuss two clinical scenarios. We will listen to the history, and then make an approach to the clinical examination. After finishing the history and the examination, we will put a clinical approach to these two case scenarios. We will start the first case scenario. A female child with an age of 4 years who was admitted to the private hospital due to progressive inability to walk. She had difficulty in swallowing over 48 to 72 hours following a trivial injury. The trivial injury was a falling from bed. She had inability to move the upper and lower limbs, increasing rapidly during that day, and she was transferred to the Children Welfare Teaching Hospital in Baghdad. So in this scenario, you have a 4-year-old child who had a trivial injury falling from bed, and after that the family noticed that she had inability to walk that was progressive, and they noticed also inability to move the upper limbs and swallowing difficulty. All that progressed over 48 to 72 hours. So this is the case, the chief complaint and the description of her history. So the initial approach to this child, first of all, we have to proceed to the examination. We have to complete the history and to proceed into the examination so that we can put a clinical approach. But what else we need to know in the history? We finished the history of present illness. She was admitted, and as a physician, we received this child. What else we need to know? Patient's history. We have, let's discuss the points on the orange highlighted side. We have to ask about the preceding febrile illness. So this rectangle or this text box is on the right side is talking about the formal points that need to be discussed with the family. And on the left side, the answers or the patient's story. So we need to ask about any preceding febrile illness. احنا كان عندنا طفلة 4 سنين اجت عندها acute paralysis, inability to walk, progressive, associated with swallowing and upper limb weakness. ايش راح نسألها؟ Preceding febrile illness, sphincteric changes, pain or sensory symptoms, other neurological event that may indicate central disorder, and we will discuss later what are these features indicative of central disorder. Past medical history, vaccination history, family history, drug and trouble history. كل نقطة من هاي النقاط راح نبين الclinical significance مالتها. First, she had history of febrile illness 3 weeks before the onset of the neurological event. It lasted 5 days. She was febrile. She had sore throat, reduced body activity. She had malaise and reduced feeding, and she recovered on the 6th day. So there was febrile illness. After 3 weeks before the onset of the progressive inability to walk, she had no sphincteric changes. She told her mother that she had pain of her in the limbs and needs rubbing. تحتاج أمها تفرك الهيام. She complained of no other neurological symptoms like visual, hearing, disturbed consciousness, or seizures. She completed her vaccination up to the national schedule. Her past medical history is negative. She had no similar event, personal history, and no similar history in the family members, in the first degree members or remote kins. There was no exposure to drug, toxin, and negative travel history. Now, why did we ask about these features? Let's continue the examination. Let's complete the examination, and later we will discuss the differential diagnosis. The child is conscious and coherent. She had nasal quality speech. She had nasal speech. She was tachypnic. Her respiratory rate was 46 breaths per minute, which is maybe an indicative of decreased effort of respiration. She had oxygen mask, and oxygen was administered, and oxygen was supplied to the child by the oxygen mask. The temperature was normal, blood pressure and pulse rate was normal. So the only vital sign affected was her respiratory rate. She had no skin manifestation, no dysmorphology, and good body build. She had no abnormal movement, but I noticed that she had a plantiflexed posture of both feet with paucity of movement of her limbs. كانت حركتها قليلة بكل الأطراف. She was wearing napkin. She had no sphincteric disturbance. She can control the urination and defecation. She had normal urination and defecation, but because the mother was unable to take her frequently to the bathroom, she preferred napkin, using napkin. Physical examination of head, neck, chest, and abdomen were normal. The cranial nerves examination was normal, except that she had no nasal speech, and she, on examination, the uvula couldn't lift in the midline, and she had weak gag reflex. She was flaccid throughout her body. She was flaccid, and she had reduced power. Both upper and lower limbs had a grade 0 and grade 1, grade 0 in the lower limbs and grade 1 out of 5 in the upper limbs. Deep tendon reflexes were absent. Her growth parameters were normal, and she had no muscle pain, but whenever she felt discomfortable. She was discomfortable and had normal muscle bulk. Then the child has من هذا examination flaccid symmetrical quadriplegia. هسه راح نجي على الهيستوري. An initial infectious event followed by inability to walk with weakness of the upper and lower limbs. من عندي infectious event, this may indicate with a gap of 3 weeks. This may indicate autoimmune process, as in Guillain-Barré syndrome, which is post-infectious peripheral neuropathy. أو ممكن أن يكون عندي autoimmune process involving the spinal cord, and both of them can cause flaccid symmetrical quadriplegia. ممكن especially بالspinal cord lesion ممكن واحد يقول ليش يكون عندها flaccid quadriplegia and absent reflexes. ممكن بالacute stage يكون shock state of spinal cord تنطينا features of peripheral lower motor neuron changes. But usually in the spinal cord lesion, the weakness or the features is usually asymmetrical. She has areflexia, which may be indicative of peripheral neuropathy, as in Guillain-Barré syndrome, or acute stage of a spinal cord lesion. She had no sphincteric changes. Again, this occurs in Guillain-Barré syndrome or muscle lesion. It is unlikely. No sphincteric changes is unlikely in a spinal cord lesion, but may occur. They may occur. لكن من ما عندي sphincteric changes, this is in favor of Guillain-Barré syndrome, muscle or peripheral nerve disease. She had no feature of central involvement. شنو هي الفيتشر؟ ما عندها seizure، ما عندها loss of consciousness، ما عندها behavioral changes. هذه features of central involvement. إذا we ruled out تقريبا central nervous system disorder. There was no motor level. إذا spinal cord lesion is unlikely. Sensory examination could not be applied in this uncooperative child لأنه كانت irritable, crying, uncooperative. فممكن ما نقدر نفحص sensory examination. There was no fever throughout the disease. من عندي fever, it is in favor of CNS infection أو poliomyelitis. ما عندي fever, it is unlikely. هذه ممكن تكون in favor of Guillain-Barré syndrome. There was negative family history of similar illness and negative personal history. ما كان عندها حالات مماثلة سابقا ولا بالفاميلي history. إذن periodic paralysis, which is an inherited disorder, autosomal dominant, is unlikely. But this can be the first time. This can be the first time. يعني هي ممكن يكون عندها negative family history وهذه أول مرة تجي بيها أول مرة للperiodic paralysis. Trivial trauma need to be considered. عندها trivial trauma قد تكون بسبب الويكنس وقد تكون هي السبب للويكنس. It may cause spinal cord lesion. لكن كونها trivial, it is unlikely that she has a spinal cord lesion. But it should be considered. She completed her examination and there was no recent vaccination and there was no history of recent vaccination. Completed her vaccination, then poliomyelitis is unlikely. It is usually should be considered in a child with that is incompleting his vaccination program. أيضا الvaccination, history of vaccination followed by such cases ممكن may be suggestive of vaccination-induced lesion. Vaccination-induced lesion أو disorder like Guillain-Barré. يعني بعض أحيان الجوليان-بري may follow vaccination, some vaccinations. إذا completing her vaccination is unlikely to suggest poliomyelitis. And بالعكس لو كان عندها recent vaccination followed by inability to walk, بالعكس هذا ممكن أن يكون highly in favor of autoimmune process like Guillain-Barré syndrome. There was no family history وهذا unlikely suggesting periodic paralysis. إذا إحنا من الهيستوري والclinical examination قدرنا أن نخلي approach بكل مرحلة كان الابروتش هو highly in favor أو the differential diagnosis كانت highly in favor of Guillain-Barré syndrome. This is the algorithm approach that was discussed in the acute flaccid paralysis lecture for the 5th year. You can refer to this lecture for the 5th year grade. For the 5th grade. إذن اللي عندي هي طفلة جدتي with acute, everything happened within 48 to 72 hours. Flaccid, she was hypotonic and she was quadriplegic. So she had acute flaccid paralysis. According to this approach, you can demonstrate, this approach demonstrated that the problem or the localization is in the peripheral nerve. In the peripheral nerves, it is bilateral, so we are talking about Guillain-Barré syndrome or toxic neuropathy. There is no history of toxin or a drug exposure, so Guillain-Barré is more likely. So Guillain-Barré syndrome is one differential diagnosis: spinal cord lesion, autoimmune or compressive or infectious. The distinguishing feature of a spinal cord lesion are 4 cardinal features: persistent localized back pain, asymmetric weakness, marked motor and sensory level bladder dysfunction. وهذه كلها ما كانت موجودة عند الطفلة. Botulism, this is unlikely the age of botulism. Usually it is infancy age group, and usually it is of descending pattern of weakness. Acute myositis, she has no that muscle pain. And poliomyelitis, the child was completely vaccinated, and usually poliomyelitis has asymmetrical weakness and fever and meningismus. The diagnostic workup: acute flaccid paralysis, bilateral, asymmetrical, highly suggestive of Guillain-Barré syndrome. We have to do CSF analysis to see the albuminocytological dissociation, and this child had 7 lymphocyte and protein was 90 milligram per deciliter. So this is nearly normal, and the protein is elevated. So this is this is a dissociation, highly suggestive of Guillain-Barré syndrome. The electrophysiological study showed absent F wave, conduction block, and distal latency prolongation, again suggestive of Guillain-Barré syndrome. Here, neuroimaging is not indicated, and you can refer to the 5th grade lecture, acute flaccid paralysis lecture, for the indication of neuroimaging in a patient with acute flaccid paralysis. We have to admit this child to the intensive care unit. Why? Because she had a flaccid quadriplegia, she had bulbar involvement, it was rapid progressive, although the word rapid indicating a deterioration or progression over 24 hours. It is more rapid than 48 or 72 hours. And vital capacity equal or less than 50%, or autonomic instabilities are again indications for admission to the intensive care unit. This child needs an admission to the intensive care unit. She needs respiratory support, IV immunoglobulin or plasma exchange, and the more feasible and easily applied one is the IV immunoglobulin. She needs supportive treatment. You can refer everything about the supportive treatment. You need to know in the AAFP or acute flaccid paralysis lecture for the 5th grade. She needs social and physical support. Case scenario 2. A previously healthy 11-year-old boy presented with persistent headaches for the last 4 days despite a treatment with acetaminophen and ibuprofen at home. She has had intermittent emesis and tactile fever for the last 3 days. Minimal oral intake over the last 36 hours. There was no history of a trauma. He has had recent upper respiratory tract symptoms 2 weeks ago. He's more sleepy and unresponsive. He was more sleepy and unresponsive, and he develops shaking movement on the left side of his body. In the emergency room, IV diazepam was started, which promptly stops the seizure activity. So this child briefly was well before. He had no past medical history, but he developed headache and vomiting. This vomiting and fever, the fever did not respond, and his condition wasn't recovered or improving by acetaminophen and ibuprofen. On his way to he developed a seizure on the left side of his body, and that was stopped by IV diazepam. So headache, fever, and vomiting with reduced activity may be indicative of a serious condition like this one in this patient, like CNS infection, or less serious condition like upper respiratory tract infection. You have to think of tonsillitis, otitis media, sinusitis, and also typhoid fever need to be considered. But because of the presence of focal deficits like seizure, the seizure, shaking movement, or clonic seizure on the left side of his body, because of this, we have to think of more serious illness. It is unlikely that this is a febrile convulsion because it is beyond the age of febrile convulsion. He's 11-year-old child. We have to complete the formal history to gather more information, and really there was nothing was remarkable regarding the other history parts. On examination, he was febrile, his temperature 38.6 degrees centigrade. His weight is normal. He was unresponsive to voice commands, but to pain with shallow respiration. His head shows no signs of a trauma, The pupil was equal 3 millimeter and reactive to light on both sides. There was no papilledema on fundoscopic examination. His oral mucosa is moist with no oral lesion. His neck is supple without adenopathy. Heart or physical examination is normal. He exhibits no purposeful movement. He had disturbed level of consciousness. His corneal reflex, oculocephalic, oculovestibular responses were intact. He has increased tone on the left side of his body and brisk reflexes, brisker on the left side. His meningeal signs were negative. Then, in the child can end a fever, fever, focal seizure, vomiting, headache, and disturbed level of consciousness. Fever, disturbed level of consciousness, focal and neurological deficits are indicative of serious condition like CNS infection. So first of all, we have to think of encephalitis. Again, we have to think of meningitis. It can be put on the placed on the point 2 as meningeal signs were negative. We have to think of localized brain infection like brain abscess. We have to think of post-infectious autoimmune encephalitis as in Adam. And we have to put other differential diagnoses لكن أول 3 أو أول 4 اللي خليناها encephalitis, meningitis, brain abscess or post-infectious autoimmune is very important. So what are the diagnostic workup? We thought of CNS infection, then CSF analysis is important, and diagnostic, but it is contraindicated in this child. Why? Because we need to do brain CT or MRI. It is contraindicated because the child had disturbed level of consciousness and he had something indicative of focal lesion. So risk of herniation is high, and we need to to postpone CSF analysis. Instead, we have to do brain CT, MRI, and to start the treatment. We can do infectious screen, blood and urine culture and sensitivity. The blood culture and sensitivity مفيد جدا إنه. بالmeningitis, its diagnostic yield reaches up to 90 or 95%. Other metabolic profile and EEG. In the seizure, focal seizure, we have to do EEG. إذن الdiagnostic profile is highly suggestive of herpes simplex virus type 1 encephalitis. شلون؟ كان عندها normal complete blood count and chemistry and liver function. كان عندها toxicology screen in urine and serum normal. The head CT scan without contrast was normal. Lumbar puncture is done. بما انه السي تي سكان كان نورمال ما عندها radiological features او contraindications. كان عندها neurological contraindications لكن ماكو radiological contraindications. So it was possible to do lumbar puncture. She had an elevated white blood cell and elevated protein with normal glucose. Gram stain and culture were negative. Treatment, this child needs admission to the intensive care unit. IV loading doses of phosphonatoin لأنه كان عندها seizure. And we have to start empirical treatment, acyclovir, ceftriaxone and vancomycin. هاي empirically سواء بعدني ما واصلة النتيجة، ما مسوية cerebral CSF analysis، بعد ما واصلة النتيجة ننطي these 3 drugs. But when the CSF analysis, especially PCR for herpes simplex virus result arrived, it was positive. We can delete or stop ceftriaxone and vancomycin and complete her treatment with acyclovir. Again, she needs supportive treatment. Then, child with fever, headache, vomiting, we have to think of upper respiratory tract infection plus minus or typhoid fever. In cases that fever persisted, condition deteriorated, or show any features of central involvement like seizure and focal seizure in this child, then we have to think of more serious condition like CNS infection. الدرس الثاني الدرس المهم اللي بالإضافة للديفرنشال diagnosis والclinical approach إنه when you try to do CSF analysis لأن هو الdiagnostic test you have to think of to consider the contraindications. ممكن يكون عندي clinical contraindications, ممكن radiological, ممكن both. And this child, although she had ممكن كان انه تبدي الانتيبيوتيك والاسايكلوفير antiviral postpone lumbar puncture until the child's condition improved. وممكن في بعض الأحيان إذا كان radiological feature has no contraindication, ماكو features, radiological features indicative of increased intracranial pressure, ما كان عندها papilledema, ممكن أن نسوي lumbar puncture under certain precautions. And the most important thing is that in addition to considering lumbar puncture and the contraindication, we have to admit this child and start a treatment before lumbar puncture. For both case scenarios, you have to refer to the 5th grade lecture for more information, and there is a handed sheet of a neurological examination in pediatrics by Dr. Nebal Wail. I would like you to refer to this for the neurological complete neurological examination. This will be uploaded in the pediatrics 6th grade site. Thank you.